It's my honor to be here in this wonderful meeting and to share with you my experience about the bile duct reconstruction in living donor liver transplantation. And I have nothing to disclose. We know that the history of liver transplant could be traced back into 1963 when Dr. Staudo performed the first case in human. And then after 20 years, it was proved as a definitive treatment for patients with end-stage liver disease. And in 1990, Dr. Strong from Australia performed the first successful case of living donor liver transplant in the pediatric patients. And now it's a primary option in Asia countries. And let's take Taiwan for example, that we have very low organ donation rate from the deceased donors. And the donation rate is about 5 to 7 cases per million populations. So for our patients with end-stage liver disease, most of the liver transplant were done from the live donors. And to compare with the deceased donor liver transplant, living donor liver transplant could shorten the waiting time and to prevent from the patient dropout, especially for the HCC patients. And it's a timely option for the acute liver failure patients. And also, the donors are healthy individuals, so the graft quality can be assumed to be better. And the operation was done in a controlled condition, so the cold ischemia time can be shortened and to reduce the risk of ischemia reperfusion injury. So overall, the outcome can be more favorable as compared to the deceased donor liver transplant. But there are certain issues remains to be debated in living donor liver transplant. And the first and the most important is always the donor safety, and followed by the graft selection, the left versus right, when the small graft favors the donor safety and the large graft favors donor outcomes. And then followed by the several surgical techniques, including the portal inflow and modulation that to prevent from the graft injury and small for size syndromes, and the hepatic venous outflow reconstructions, and the construction for small caliber hepatic arteries, and our topic, the bile duct. We know the bile duct receives blood supply from the peribiliary vascular plexus that was derived from the hepatic arteries. So transection of the higher plates during donor hepatectomy will reduce the artery supply to the bile duct that will induce hypoxia and ischemia reperfusion injuries. So overall, it will increase the risk of biliary complication in living donor liver transplant. And ideally, the common hepatic duct is merged by the single left and right hepatic duct, but variation do exist. And to prevent from the left side hepatic duct injury, the higher plate deviation line was usually slightly right shift in right lobe donation. So the prevalence of the multiple bile duct openings on right lobe graft would be higher than expected. And this is data published by the Korea group that using the intraoperated cholangiogram in 300 cases of living donor liver transplants. The authors identified that 37% of the living donors would have bile duct variations, while the type 3 variations, that is right posterior hepatic duct drain to the left hepatic duct, is the most common type, followed by the trifurcation of the intrahepatic bile duct. So the bile duct reconstruction for grafts with multiple bile ducts can be classified into the enteric approach, that is using the hepatico-jejunostomy, or the ductal approach, that is using the unification ductoplasty or double duct-to-duct anosmosis, or the hydro-to-duct approach. And the first one is the unification ductoplasty that was proposed by Professor C.M. Low from the Queen Mary Hospital, Hong Kong, China. And in this method, the medial wall of the two bile ducts were vertically incised and sutured transversely to create a large opening. But in my experience is that tension might exist between the two bile duct openings. So the bile duct anosmosis may look like this, angulated and a little bit twisted. So after graft reperfusion, the liver parenchyma may become more congested, and this opening may be covered by the liver parenchyma, and reconstruction can be more difficult, especially for this angulated orifice. So the next method is called the double duct-to-duct anastomosis, and In this method, the bile duct is reconstructed by either the recipient's right and left hepatic duct openings or CC duct as an alternative. In this method, there is no tension between the two bile duct openings. And this is a result published by the Chang'an Memorial Hospital Linkou branch from Taiwan. And the authors showed that 41% of the patients will develop the biliary complication in two years. But most of the complication could be managed by the radiological intervention by ERCP or PTCD. And the third one is called the hilar to duct approach. And one of these methods is called the dunking with mucosa eversion technique. And this is also published by the Korea group. And in this method, the two bile duct openings and the interductal connective tissues were anchored to the recipient's common hepatic duct. And also the external drains were used to drain each of the bile duct openings. And results showed that using this technique, the overall bile duct complication could be slightly decreased as compared to the unification ductoplasty method. So how about the overall outcomes? This is an international study of from 18 transplant centers, consists of the 3,600 patients. And results shows that multiple bile duct anosmosis as the most significant risk factor for bile leakage. And patients with bile leakage will prolong the hospital stay and increase incidence of late biliary stricture. So the brief summary here is that multiple bile duct opening is inevitable and account for 30 to 40% of right lobe liver grafts in living donor liver transplant. And the increased number of biliary osmosis is associated with the increased risk of biliary complication, especially the early bile leakage, and results in a prolonged hospital stay and the risk of late biliary stricture. And here is a comparison between the three techniques. The unification ductoplasty can create a single large orifice and enable one osmosis for two bile duct openings. And it's less time consuming on the recipient's operation. But tension may exist between the two bile duct openings, and the bile duct opening can be twisted after reconstruction. And it is not indicated for the bile ducts that are distant apart, especially for type 3 bile duct variations. The double duct-to-duct anosmosis is tension-free between the two bile ducts, but of course, it's more time-consuming since you need the two anosmosis. And the increased number of the anosmosis may increase the risk of biliary complications. And the third one is the hilar to duct method. It's tension-free between the two bile ducts, and it's also a single orifice for two bile duct openings. But the concern is that when the bile duct corners are not securely anchored to the mucosa of the recipients, they may increase the risk of bile leakage. So overall, which one is the most clinical relevant to effectively prevent from the biliary complication in living donor liver transplant? And I would like to share with you our experience. And this is a retrospective analysis of our adult living donor liver transplant recipients between 2011 to 2022. And we exclude the retransplant case and the left lobe case. And after review of 200 cases, 24 cases were further excluded because of a perioperative mortality due to the vascular complications and patients using hepatococyginostomy and patients with more than two bile ducts. And then the 216 patients were enrolled for biliary specific outcome analysis. And here our definition of biliary complication is a having grade 3 complication. That means patient needs a ERCP or PTCD interventions. And the complication can be defined as early, that's within 19 days of post-transplant, or more than 19 days post-transplant. That's a late complication. So the first question here is that whether liver grafts from the two bile ducts is associated with a higher biliary complication rate. So the patient were divided into group 1, that's patients with single bile duct, and group 2, that's patient with double bile ducts, and that's about 30% of our population. And here our data show that the early bile bile leakage rate and the late biliary complication rate were not significantly different between the two groups. And it's about 12 to 13% for early bile leakage and about 20% for late biliary stricture. And so the next question is that which method is the most optimal one for biliary reconstruction for allograft with 2 bile duct openings? So here the patients in group 2, that's a patient with 2 bile ducts, were divided into 3 subgroups. The group A was say patients with unification ductoplasty. And the group B were patients with double duct-to-duct anastomosis, including 6 patients were anastomosis using the recipient's right and left hepatic duct, and 12 patients were using the CC duct as an alternative. And group C are patients using the hilo-to-duct approach. And here the data showed that the patients using the unification ductoplasty was associated with a significantly higher early biliary complication rate. Is about 25%. And surprisingly, there's no case of early bile leakage was noted in the group C, the hilo-to-duct approach. So here I would like to share with you one case of our patients using the hilo-to-duct reconstruction for 2 bile duct openings in living donor liver transplants. And the recipient is a 69-year-old male with hepatitis B and hepatocellular carcinoma post-embolization and with 3 recurrent tumors. And the donor was his 28-year-old daughter planning to donate the right lobe liver without middle hepatic vein. And the pre-transplant MRCP showed type 1 bile duct, but the early bifurcation of the right anterior posterior branch was noted. And this donor was underwent by a pure laparoscopy approach. And on the back table, we can see that there are separated right posterior and right anterior hepatic duct on the same hilo plate. And these 2 openings were far apart from each other. So the unification ductoplasty is not indicated. So here we use the hilo-to-duct anastomosis with a Y-shaped biliary stent. And here's a video clip. And the first step is the anastomosis of the posterior wall. And here we use the 60 PDS interrupt suture with nuts inside the lumen. So the anastomosis began with the anchor of the right posterior hepatic duct to the common hepatic duct posterior wall. And make sure that the angle is securely anchored. And followed by the interductal hilo plate to the common hepatic duct posterior wall. And then followed by the anchoring of the right anterior hepatic duct to the common hepatic duct posterior of the recipient. Also, the angle should be securely anchored. So the anastomosis is completed for posterior, and this is two bile duct openings here. And the next step is the insertion of the homemade Y-shaped stent. And here we use a French 8 NG tube and cut the tip and then split into the Y shape with each arm about 2 to 3 centimeters. And then we make a small incision over the 12 o'clock position of the recipient's common bile duct. And then pull through the stent into the recipient's common bile duct and insert one arm of the stent into the right anterior hepatic duct. And the other end into the right posterior hepatic duct of the graft. And then the stent was fixed to the common bile duct by a absorbable suture. And the next step is the anastomosis of the anterior wall. So again, this is an interrupt suture between the right posterior hepatic duct and the interior wall of the recipient's common hepatic duct. Then followed by the interductal hilar plate anastomosis. And the anastomosis of right anterior hepatic duct and the anterior wall of the common hepatic duct. And it's completed. So in my opinion, that using this method, the medial wall of the two bile ducts are not joined together, so it's tension-free between the two bile duct openings. And also the anastomosis was done on a smooth plane of the hilar plate and the recipient, and not on a twisted reconstructed orifice. And also the angles of the two bile ducts should be securely anchored to the recipient's common hepatic duct to ensure a better regeneration of the epithelium. And also we use the Y-shaped stent could ensure better biliary drainage of the two bile ducts that will decrease the risk of early bile leakage. But although the risk of early bile leakage could be reduced, but the late biliary complication remained high in group C patients and maybe even more higher than group A. And this is one of our case. This is a 46-year-old male and received donor liver transplant from a right lobe graft. And the two bile duct openings were reconstructed by this hilar to duct approach. And there was no early bile leakage. And the Y-shaped stent was removed 2 months post-transplant. But the ERCP at 4 months post-transplant showed the biliary stricture here. So we treat the patient with a PTCD for 9 months, and then the drain was removed. And currently he is PTCD free for 1 year. So which method can overcome the bile duct complication in living donor liver transplant using a graft with multiple bile duct openings? My personal opinion is that the hilar to duct approach with Y-shaped stent could effectively reduce the risk of early bile leakage, but risk of late biliary stricture remains high and should be further investigated. And this is my institute. It's located in Beitou district of Taipei. And the most importantly is nearby some tourist spots like Beitou Hot Spring area and Yangmingshan National Park. And we always look forward to have a further communication with our international experts. And this is my team. I really appreciate the help from them. And thank you for your attention.